Well, Harry, a very hard act to follow. I can't make all of those fantastic jokes, but I am very grateful for you to invite me here to give you a bit of an update about what's happening in stroke. And I think we all know that stroke is a very common and disabling problem in Australia and elsewhere in the world, and I doubt that there are many of you in the audience who haven't been personally touched by stroke or know someone who has had a stroke. So let's dive in my short time. So I've been asked to talk about prevention. So in the primary prevention space, the most recent research that perhaps is notable is the Pathways 2 trial that was completed in 2015. And this is for looking at persistent hypertension, drug-resistant hypertension. We all know that hypertension is still a major risk factor for stroke and other diseases, and you can see here that the recommendations that are coming out from that study is that we take an A plus D plus C plus D approach, and then spironolactone if that is the case. We need to really keep attention on this issue of hypertension in our patients. In terms of the other new areas where we're starting to gain significant efforts and interest and research, it really is in the areas of exercise, physical activity, and changing sedentary behaviour. What we see consistently in the literature is that changing any of these areas can have a significant effect on reducing the risk of stroke and other cardiovascular diseases. So, in Australia, we have one of the eminent researchers, David Dunstan, who works in this space. And really the message that we're getting through, trying to get through to people is the move more and sit less message and breaking up of sitting time. This is actually very advantageous for people with stroke as well, because it's hard to get back on the exercise wagon, but even advising around moving more and sitting less is worthwhile. So from the recent research, again, you see that even reducing the number of hours that we spend sitting in watching television as a marker of sedentary behaviour, you really can make quite significant reductions in the risk of death and cardiovascular disease. How we do this is always the challenge. But what we see is the value in making some changes right across this spectrum. So from reducing long periods of sedentary behaviour to increasing light intensity activity such as walking and doing moderately vigorous activity. And as I said before, there are independent effects of each of these modifications, but how we do them is challenging. The important thing also to note from the prevention side is that if we are active and able to make these changes prior to stroke, when people have a stroke, if they are physically active, they have a reduced incidence of death, reduced adverse events, improved recovery, and an overall better outcome. So it is an important target for us. I was recently at the World Health Organisation 68th Western Pacific Region meeting a week ago, and the WHO is really latched onto this as a major area for activity for them, looking at physical activity into the future, and a global plan of action will be coming out in 2018. And just to note that they also practice what they preach, and it was quite surprising to me that they break into dance every now and then during the meeting just to break up their sedentary behaviour. So the other thing that would have been announced, and you probably already know about this, is the Healthy Heart Initiative. This has obviously been running in some other countries. This was announced in the budget this year, with $10 million to increase access to walking and other physical activity programs, and some of that money will be coming to you guys to look at education around physical activity and nutrition. And I'll note that if you're on Twitter or if you have colleagues in the UK, that this has been a major area of emphasis for a number of years now. And in fact, even a recent report was lamenting that there are a lot of medical students and young doctors who are not being trained in being able to feel confident to give advice about lifestyle and physical activity. And of course, if we get changes in behaviour that's good for your heart, it's good for your brain also. So the other area that we really are focusing on exercise is in secondary prevention, because it is an area that, apart from our medication use, we need to pay attention to. And you'll see this exercise is medicine conversation happening a lot. And I'll also note that, as you would probably also know, that stroke is associated with significant increased risk in dementia, with 10% of people developing new dementia quite early after stroke, and 30% by 3 years having significant cognitive impairment that is in addition to their primary burden of stroke. And at the Florey, we're involved in a number of research projects looking at exercise and its effect on reducing or maintaining hippocampal volume and that's association with memory. And there is a lot of work happening here to show that even in older age, this can be beneficial for people. So if we move on to the acute care space, we still have the FAST message. We've just had Stroke Week a couple of weeks ago. It is still really important that we get people to hospital as quickly as possible. And only recently, really, in 2015, the clot retrieval evidence finally came to bear. And we are now seeing a rapid increase in the research, which is confirming that if we can get people with ischemic stroke into hospital within 4.5 hours, not only is the clot-busting drug important and helpful, but now some of those cases are eligible for clot retrieval. And you can have incidents where people come in with a dense hemiplegia and other serious middle cerebral artery problems and walk out within a couple of days. So it really is a miraculous treatment if we can get it, not without some risk, but this is a really significant improvement and change, and has created some changes in health service organisation to the point where we're looking at getting several important centres of delivery of this treatment in each country, in each state across Australia. The other new thing that's just come out is the clinical practice guidelines for stroke. Now, in the past, we actually had a 7-year delay between the last ones and these new ones, and they're now on an online format. So the goal of the Stroke Foundation is to have them constantly updating. So rather than it being a large lag with evidence, if we can get this online platform going, then as these new treatments come up, we'll be able to amend the guidelines and have them available. So I encourage you to have a look at those if you're interested. The other area, of course, is the TIA, and there's still debate over whether we should call it a transient ischemic attack or a stroke. But TIA still needs very urgent attention, and there are a number of new recommendations in the guidelines that you're welcome to look at. The most important message being that if people come to you and, of course, have had some symptoms, please urge them to follow on with their referral. So the thing that we're excited about in Victoria, it's been running for some time now, is the Victorian Stroke Telemedicine program. And this is something that we hope is going to be expanded certainly into New South Wales, but also into other parts of Australia if funding becomes available. Right now, this is a way of connecting rural or remote, not so much remote in Victoria, we don't really have quite as much of that as there is in other parts, but certainly rural and regional areas with expert neurologists using the telemedicine system. So you can see on this slide on the top box that the system is put at the bed end, and the neurologist can actually view the patient, ask the staff questions, review their CT scan, and make a determination as to whether they're eligible for thrombolysis, which can then be delivered at the bedside, or whether or not they need clot retrieval, and then they can be transferred to a facility. So you can see from the results there that they're getting a significant number of patients seen in this manner, and as I said, I hope this will be expanded. So the other thing that's going to be happening that's new, and there'll be one I think in Sydney also, but again just focusing on the major areas, is the stroke ambulance. This has now been launched in Melbourne. Essentially it has a CT scan in the ambulance, and the goal of course is to have faster communication with a hospital and to get people to hospital more quickly so that they can have their treatments more efficiently and have a better outcome. But there are clear gaps and inequalities in care, and we know that right across the country. We know it's challenging in regional areas. Our efforts in Indigenous health are really on the increase, but still incredibly difficult. And of course, there are other challenges that we face in just delivering good care across the whole spectrum. I just want to focus really in the last bit on young stroke as an area. It's something that I've been very interested in for the last several years. We have over 3,500 young people, and that's not including children. We also have paediatric stroke, but I'm talking here about people between the ages of 18 and 55 each year who have a stroke, and it's increasing rather than decreasing in incidence. And the photo over on the right was actually taken this week. We had a consumer forum with stroke survivors. There were 30 in the room, and this is one of the group of young people who came to that event. So the main thing that they really have difficulty with is that a lot of people, they have difficulty presenting to hospital with people not believing that they've had a stroke or not even considering that they've had a stroke. So there's a significant education piece that needs to be ongoing here. And also, once they've had a stroke, they often face the problem that people don't believe that they've had a stroke. And so it really is quite a significant challenge for them. They're also less likely to be offered and given secondary prevention advice or medication. So this is an area we really need to spend a bit more time on. Earlier this year, we had some wonderful young medical students who completed work in doing some unmet needs work, both with in-depth interviews and also with an online survey of this group. And they have very powerful stories, as you can imagine. One of the significant things is their unmet psychological and emotional needs. And this is an area where GPs really are at the forefront. And that came out in a lot of stories about the importance of having someone that they can talk to who can also try and assist them to access services that help support their unmet needs. So I think we are hoping that we can develop a young stroke clinic that might be virtual and available broadly. We're sort of just starting on that vein. And the other thing to mention is that this fatigue issue for them is a very significant area, and I'll touch on that in another minute. So recovery is the new frontier in stroke medicine, and I'm very excited about that. We've been working hard to try and get people really rethinking what we need to do about promoting recovery and brain repair. And this is a photograph of a group that I convened last year in the US, looking at how do we progress the research domain with recovery. I think the main thing that we need to offer people here is hope. There is significant change that occurs after stroke. It is ongoing and it doesn't just stop at 6 months. And there are lots of things on the horizon. So we've got new drug targets coming through the pipeline. There are new robotic systems for getting people active early. There's new brain stimulation treatments that are being tested and other training approaches. So there's a lot of activity in this space. And I just thought I'd share with you the fluoxetine trials, because they're going to be coming out this year, I'm sure. You can see that there's a really significant series of studies here, and that these are all looking at fluoxetine as a mechanism or a treatment for promoting recovery. The mechanism is uncertain, but these results will be coming out later this year, I suspect. So I think the message here is the road to recovery is very long, and people need support along the way. So finally, just to help with recovery, some of the innovations recently are the Enable Me platform from the Stroke Foundation. This is where carers and stroke survivors can sign up, create communities, talk to each other, share information, get knowledge. And then the other thing is the Inform Me platform, which is for health professionals. So these two things are really great resources if people are looking for somewhere to go to get information. So I just want to thank you for your attention and to say I love my GP, and I think if there's anything that we can do to help you, please let me know. Thanks.
Thanks very much, that was wonderful. Again, we have time for a few questions. No?
Thank you very much for a great presentation. My name's Jessie Johnston and I've worked for a long time in the Northern Territory. When we talk about stroke nationally, let's not forget a certain group of our population, which is Indigenous Australians, and particularly in the north, where incidence of rheumatic heart disease is 2%, 1 in 50 people. And the burden of stroke on this population, and there's nothing sadder than seeing a young Indigenous person in a wheelchair affected by having had a stroke. So let's just think about acute rheumatic fever, which is a disease of poverty and overcrowding. It used to be common 100 years ago in Sydney and Melbourne. We don't think about it very much, but this is a big issue in our national consciousness.
Absolutely, absolutely. So I guess the two comments I'll make there is that we are fortunate to have Alex Brown and a Centre of Research Excellence in Indigenous Health, and we work with them with stroke. It is a significant challenge, as you say. The other thing is the rheumatic heart disease. At the World Health Organisation meeting last week, there is likely to be a resolution for a massive program on eradication of rheumatic heart disease. It's taken them, I think, 10 years to get to the table, but it's going to be discussed at the World Health Assembly next year. So there might be some good news from a WHO perspective in terms of resourcing some of the important treatments for eradication. So that's great.
Question on that side, please.
Thank you very much. My name's Mukesh Hakawal. I'm a GP in Melbourne's western suburbs. I also work with Brain Injury Australia, and many of the things that you're speaking of certainly ring very true to the agenda that I pursue over there. Thank you for your presentation and your messages of hope. And I think that one of my key concerns, I guess, in this area is certainly in my geographic area, is a complete lack of rehab services, and how poorly people do if they don't benefit from those services. And I think one of our roles in general practice land is to source those resources and try and advocate for funding for those things, because actually the people who are suffering from these issues actually don't get access, partly because they're not there, but partly because of funding. And the mechanisms that we have are really very limited. So thank you for your advocacy around that, and I'd be interested to see what you think about the very strong role of rehabilitation after brain injury.
Yeah. What you describe is that the access to rehabilitation is a major unmet need for many stroke survivors. So this is discussed all the time. And of course we don't have, everything is front-loaded in our system, and yet recovery goes on for many years. So I'm absolutely with you. This is a conversation that we've been having for a long time in the recovery space. I think the major things that are likely to, and there is some hope around this area, are likely to sort of be changes in the system that may help access are probably the development of some of the tele-rehabilitation approaches. We still don't have a funding model for that particularly, but I know that there are areas in speech and aphasia therapy, for example, that are now fully platformed and so accessible to people in lots of different geographic regions. But there really is a huge, huge problem of not being able to access those services. And we do talk about it all the time, and there's no easy solution, but we are testing a few different approaches with communities around how do they access rehabilitation. And here I'll say that the stroke associations in some states are very active in this space, and they're creating community hubs where they're trying to have a hub in each health region that is really organised, somewhere that's central to allow people to congregate together and support each other with their recovery. But we've got a long way to go with that, yeah.
We have time for one more question.
Keep it short.
Thank you. Amelia Stevens, I'm a GP in Brisbane. My question is around the increasing incidence in younger people. Mm-hmm. So what sort of risk factors are we seeing in this population? So from a prevention point of view, is it the traditional risk factors of hypertension and hypercholesterolemia, or are there other risk factors that are not elucidated yet, or is there further work being done in this space?
Yes, there's a lot of work being done. I'll try and keep it brief and maybe we can talk further. What we are seeing is an increase in the traditional risk factors at a much earlier age. So looking at blood pressure in young people is really important. But there also are a number of other risk factors that we know of and some that we really don't know of. So we've got a combination of some potential genetic factors, we've got a combination of the traditional factors, and then we've got a big, big space where we're just going, we don't really know why you had a stroke. So it is an area that I think has not had enough attention, and that's why we're turning our gaze to it now. Thanks.
Thank you so much for being here and for your important work. And thanks again. Cheers.
Thank you.